Please welcome to our stage Dr. Christopher Lathan.
Good afternoon. I think I get to be the first person to say good afternoon, right? My name is Chris Lathan, and I'm a medical oncologist at DanaFarber Cancer Institute, and I'm going to talk to you a little bit about lung cancer. But before I do, I wanted to say thank you to Dr. Seal for inviting me to talk and giving me the opportunity to talk. And I want to echo some of the things that were said earlier about how I, too, was invested in by the church. I'm a product of that. I grew up in Springfield, Massachusetts, and went to a small holiness church called Church of the Living God, the Pillar and Rock of the Truth. I joke to my friends that I didn't see a full football game on Sunday until I went to college. I didn't even know it was possible because I was in church all day long. That's why even though I haven't been before you, it feels like home, is what I'm saying. Let's see, make sure we can move forward on the slides here. There we go. So what I'm going to do is I meant to talk a little bit about lung cancer treatment. I want to explain a little bit why I got into lung cancer as opposed to some other cancers, right? So lung cancer was interesting to me for two reasons. When I finished my training, I trained at a city hospital, and my feeling was, my goal and my calling was to take care of underserved patient populations, of communities that had looked like me. And so I went to the Dana-Farber to get this cancer education, and I found out that lung cancer was not only the #1 cancer killer, and that's some of the things that we forget. When we think about the #1 cancers, we think about breast and prostate cancer because they're the most common. Right. So those are the ones we think about. If you're a man, you think about prostate cancer. If you're a woman, you think about breast cancer. You heard a little bit about colorectal cancer. But lung cancer, unfortunately, kills more than breast, prostate, and colon combined. And yet, we don't hear about it. Well, that was the first thing. The second thing was that my own community was affected by it, and yet we didn't know. And so that's really why I came into treating lung cancer, because I realized that we needed to do more education and we needed better treatments. So I'm going to talk a little bit about disparities in lung cancer. I'm going to talk a little bit about treatments, and then try a little bit to talk about treatment equity and mention something about screening, all in 15 minutes. This slide I like to use because I think it's very helpful. It's taken from the Institute of Medicine report on disparities in cancer. And I think the most important way to look at this is you look at the differences between minority and non-minority populations as far as treatment. Disparities is really divided into 3 different categories, right? One is appropriate patient choice. People don't want something, they're educated, they understand why they don't want it, and they choose it. Nobody's trying to get in the way of that. But the other two, right, the operation of the healthcare system and then, of course, blatant discrimination, those are the things that really make up the majority of disparity. And when you split disparity out, when you think about it, there is a part that is biology and epidemiology, but I will say to you, and people who've heard me talk, I'll say it again, race is a social construct. It's a social construct. It's not a biologic construct. Ancestry gets you to genes. Ancestry, who your parents are, where they lived, and their experiences, that gets you to genes, and that's really important. But race is a social construct imposed upon us. And so we must remember that. We must remember that when we think about the biologies, diseases that you're talking about. And then most of the disparities which you'll hear about is really due to the other things there, socioeconomic status, race and racism, and other issues that, that really put people at disadvantage. So I don't want to spend too much time on this, but let's suffice it to say that lung cancer, the good news about lung cancer rates is they've come down. And that's because people have smoked less. When you think about the risk for lung cancer, the #1 risk for lung cancer would be tobacco. I always say that if I were going to list 10 causes of lung cancer, the first 8 would be tobacco. Then after that, there are some other things at a much lower rate. You heard Dr. Wingfield talk about radon. There are other chemicals, people who've worked in chemical plants, veterans who've actually been exposed to jet fuels. This is something that we're seeing more and more, people working on aircraft carriers, and also a synergy between tobacco and some of those other things. History of COPD, right? All of these things can lead to a higher incidence of lung cancer, but certainly the most preventative thing we can do is stop smoking. The good news about that is the rates have gone down, but they haven't come down to 0. And our community continues to be targeted by tobacco ads. And if you look at where the ads, there's the qualitative work we did, and somebody once said, I've never seen a sale for a 2-for-1 pack of Newports in a white neighborhood. And I think that's important, and it's important for us to remember on the preventative side. However, what you can see from this graph here is that there's still a gap between survival for whites and blacks and lung cancer, even as the overall rates have come down. And the other thing that was interesting to me and what I found out is not only do African Americans have the highest incidence and mortality rates for lung cancer, but it's African American men in particular who have the highest rates for lung cancer. And it's not just about tobacco. So even when you adjust for smoking, we seem to get lung cancer more and we die from lung cancer more. And again, this was not something that anybody was talking about. And this is where the better part of my research has been done. The other thing about lung cancer that's interesting is not only if you have a lower socioeconomic status, if you have less access to education, some of those built environment factors that you heard about earlier today that disproportionately sometimes affect our communities, well, that puts you at a higher risk for getting lung cancer, and then you have a double hit phenomenon because then it also puts you at a higher rate from dying from the disease. So there's this double hit phenomenon. Lower income puts you at higher risk for getting lung cancer because of tobacco, because of particulate air matter, but it also puts you at a higher risk for dying from lung cancer. And income is directly related to the stage of the disease. So more than any of the other cancers that you'll hear about it, the survival from lung cancer is predicted by the stage of the disease or where the cancer is, right? Early stage, you see a surgeon. And I always say, if you've come to see me, I'm a chemotherapy doctor. That means that your cancer is probably already advanced, right? And that's a concern. So what you really want is to be able to find the cancer at earlier stages because that's going to give you the best chance of survival. In the middle, if the cancer is not quite metastasized, but is in some regional areas, perhaps you'll see me and then some of my other colleagues like Dr. Wingfield and Dr. Roach who do radiation therapy, and we still have a chance to cure it. But the most important thing is to find it early, and we're going to circle back to that later. One of the things that's really important that has changed what happens with lung cancer and our overall survival rates, about 15 years ago when I started training in lung cancer, there was really only 3 or 4 drugs. They were all chemotherapy drugs. And it didn't matter what type of lung cancer you had. We treated them pretty much the same. We infused with chemotherapy and we hoped for the best. Average life expectancy was a little less than a year. Didn't matter whether we gave you chemotherapy or not. And a lot of times people didn't even want to send people to the medical oncologist because they felt that it's lung cancer and it's not going to help you if you have metastatic disease. Well, that has changed dramatically. And one of the things that's changed dramatically, and you heard a little bit about this from Dr. Mitchell's talk, is now we're talking about personalized medicine. And this is what's really important for you as you advocate for members in your community and your own family. The way we treat cancer has changed dramatically. And now we want to know not just what type of cancer you have, but what is the specific driver of your cancer in your body. And that's different. And for some of that, we have to have a little knowledge because not every oncologist, not every pathologist is trained in this the same way. So there's a responsibility for us to push those physicians, those caregivers, and also the professional folks in the pathology lab to make sure they do the right thing. So think about personalized medicine. We want to really put people in different boxes to give them the most effective treatment. One of the things that was discovered is that for a certain subgroup of people with lung cancer, there is a specific mutation. It's called the EGFR mutation. And if you have this mutation in your cancer, then instead of getting chemotherapy, people can take a pill. And this pill can have a dramatic effect in shrinking the cancer. It's not a cure, but it can treat the cancer dramatically. And this picture here, that little X-ray, you can see the one, you don't have to be a physician to understand that one of these looks worse than the other, right? And it really was after just taking this pill. And this pill was given, this is a person who had a lot of chemotherapy, and it was really the cornerstone of this personalized medicine. I can give you a pill that you can take daily. You can go back to work. We can sometimes treat the cancer for years, but we have to actually first look for it. And so this is this timeline. I'm going to go through pretty quickly because I don't want to bore everybody with it, but the original biologic work was done in the 1990s, but then really the clinical work started to happen around 2004, 2005, and then it was approved in 2009. And then there's another, we saw that there are many, many more of these mutations. We call them somatic mutations. One is called ALK. And this is another one, again, that is directly linked to a pill that you can take that can actually control the cancer for a few years. Why this is particularly important in lung cancer is, as I mentioned, we didn't have a lot of therapies. But on top of that, in the beginning, they were telling people that African Americans didn't have these mutations. The mutations were more frequent in people who self-identified as white and people who were East Asian, and they didn't see it in African Americans. So people weren't even asking. They weren't looking for it. And it took about 5 or 6 years of people to actually find a tissue, because the reason they weren't finding it is because in those clinical trials, African Americans weren't in them. So their tissue samples weren't in them. So it was really a matter of not knowing what the denominator was, not knowing how many people had these mutations. And so people were not getting life-extending medications simply because we weren't even considered part of the discussion. And so this slide is really just telling you a little bit about how things have changed. You see how that pie has changed and it's got many more slivers? There's many, many more of these mutations. And your pathologist, your oncologist, they should be testing for these reflexively so that we know if you have lung cancer, do you have one of these mutations, and can I treat you with something else? So, and we'll skip forward. This is what I was just saying a little bit about, EGFR mutations, and, these mutations are somatic. That means that this isn't really about in genes which you're passing on to your children. This is the tumor that's in the cancer. And that's really important to know because people get worried. If I have this mutation, does that mean that I'm going to pass it on to somebody else? No, this is really all about the cancer itself. And I'm going to skip forward. This is talking about some of the other mutations. This is important because this was what the frequency of these mutations based on that social construct called race that we were talking about. So for a long time, they didn't even know some of the mutation frequencies that were that we had in African Americans. And we recently did a paper about a year ago that actually we went to Tennessee. We talked to practitioners who had treated patients who were African American and who had lung cancer, and we actually compared their mutation frequencies for folks who self-identify as white, and guess what? It's the same. There's no difference. Those same mutations that are there should be checked in all groups. But we had to actually go out and prove it in a paper, and it took us, we had to go out and find a place where they had tissue samples, and so it's really, really important. And this is just talking about clinical trials, and then I'm going to move forward a little bit. I think, the take home for the sequencing and somatic mutations and personalized medicine is this. You don't have to remember EGFR. You don't have to remember ALK. What you have to remember that if there's a family member of yours that has lung cancer, and when you go to your doctor, you should say, did you test it to see if there is any specific mutations? That's it. And if they say, we don't, but next. Move on, get a second opinion. And then the other thing that you heard about clinical trials is really important in oncology. Clinical trial might not be for everybody, but there should be an opportunity to have it discussed. And I think that information can be very helpful, and sometimes it really is the only way that you can go forward and get further treatment. This is just a little bit about diffusion of technology. So we have all these great, we're making all these great advances in treatment, but it does not get to the communities in need. I mentioned earlier that African Americans have the highest rate of lung cancer, but didn't I just tell you that we weren't even getting the targeted therapies? Well, there's another thing that's happening with immune therapy, and we notice that the farther away that you get from a cancer center, the less likely you are to get some of these therapies. This slide is about EGFR, but it's also true about immunotherapy. And I didn't have a slide for that today, but just to tell you, you heard about the immune system, right? Well, what we know is that cancer is not usually visible to the immune system. It's seen as self. And so some of these newer therapies have actually found the mechanism in which the cancer cloaks itself, if you allow me that colloquialism, and they can interrupt that process and allow your own immune system to help fight the cancer. Again, it's not a cure, but it's another therapy that could be useful. And again, there's different side effects, there's different profiles, but the pharmaceutical companies, once again, we're not in those trials. And that means a lot as far as efficacy, side effects, and making sure we know that these are therapies that we could have. There's other testing that we do for immunotherapy too, looking for markers. We should know about these to make sure we're getting the therapies that we need. So in summary, we talked a lot about a few things, and the racial and class disparities is multifactorial. You heard this a little bit earlier, so I don't have to go into that. We need not only improvement in the treatments, but access to those treatments, right? And without focusing on, if we don't focus on some of these new therapies, whether it's somatic mutations, whether it's immunotherapy, then we'll have a greater gap between the haves and the have-nots. If you look at response rates and survival rates for lung cancer starting from 1970, the survival rates between blacks and whites were exactly the same. So this gap actually came after 1970. The feeling is probably that surgical procedures got better, and then it mattered who got the surgery. And guess who wasn't getting the surgery? So these things can happen over and over again. The better the therapies that we have, sometimes that widens the disparities. And the last thing I want to say is a little bit about screening, because we were talking about lung cancer. So you heard me say earlier that lung cancer is stage-driven, meaning that if it's metastatic at the beginning, you can't really cure it. But we do have a screening for lung cancer. It's a low-dose CT scan for people who had a history of smoking. Your primary care doc knows about the rules, and we, meaning people of color, are not being screened, because actually people are not utilizing lung cancer screening in general. So there's an estimation that 20% of the population could actually fall into the category that should be screened for lung cancer. Overall, it's 3%. And it hasn't really even been assessed for people of color, and certainly for rural and urban underserved. So this is another area that there's a potentially curative mechanism that we are not utilizing. And I would encourage you to push your providers, because this is what we need to do, right? We need to push our providers and need to advocate, because there are treatments out there and there are things that we can do to make things better. So thank you very much for your time.
Awesome. Thank you so much. And, I must say, Dr. Lathan is up in the north in this little place called Harvard. And, he was, when I tell you that everybody on this panel has been very important to me, when I was training, because I trained at Harvard and stayed on faculty, he was a person I went to because there were so few of us in the system. So thank you, Dr. Lathan. Thank you for your support. Thank you for being here. He said many important things, but remember, clinical trials, clinical trials, clinical trials. We have not been represented, and that's going to be part of your job. Those of you who are pastors and health minister leaders, you have to encourage your congregants to think about clinical trials. Just ask the question. And so from a lung cancer perspective, you also heard Dr. Lathan say, if you have someone in your congregation who is diagnosed with lung cancer, then you have to make sure that they've asked the question, has my tumor been tested? Has it been tested for markers? Because as you've heard, that can make the difference. Now, very quickly, because we've had a lot of information here, I do want to just ask Dr. Lathan, can you just expound a little bit? Can we get the mics turned on the table, please? Can you just expound a little bit about immunotherapy? You talked a little bit about it, but can you just give a little bit of additional information for folks?
Sure. Hello, can you hear me? All right, so briefly, there are two major, there's actually more than that, there's like 5 major therapy, FDA-approved therapies for immunotherapy for lung cancer. What we know is this. Immunotherapy can be very helpful in what we call the second-line setting. After you've been diagnosed with lung cancer, you've been treated. Your pathologist should test your tumor for a marker, right? And if you have a high expression of that marker, some people can actually start with immunotherapy and skip chemotherapy. For people who don't have a high expression, they'll get chemotherapy first, and then they can use, there's a whole number of drugs out there, but you might have seen commercials for them, a drug called nivolumab and another drug called pembrolizumab. So these are drugs that are out there, and they're FDA approved, they're not on clinical trials. And actually, I have a patient who was actually on one of the earlier trials with this drug. He's actually been called to the ministry now, and he's actually going to be telling his story. And so he's a man of color who actually, we put him on clinical trials. He responded to this drug. He responded for 2 years with metastatic disease, and now he has not been treated for 2 years, and he's out there ministering right now.
Yeah, that's awesome. Great. Thank you so much. And one of the important things to remember is that sometimes the immunotherapies may have fewer side effects. Okay, so a lot of times we get caught up in some of the side effects, and so there are ways that some of these pills some of them can be in pill form as well and taken at home. Dr. Mitchell shocked some of you when it comes to colorectal cancer screening. Age 45, right? Was that new? All right, so y'all learned something today. But one of the things that's been interesting is it's not just for folks of color. We've been finding an upswing of individuals who are younger and younger who've been diagnosed with colorectal cancer screening. And now, Dr. Mitchell, any thoughts about what may be some of the cause for that kind of earlier diagnosis that we're seeing for folks with colorectal cancer?
So, yes, Dr. Wingfield, we are actually doing research on young individuals with colon and rectal cancer, and it's very clear that we're seeing about a 2% increase in incidence in the individuals younger than age 50, so they would not have gone through regular screening. And we're seeing that each year. The thoughts are, number one, this might be related to fast food industry and the consumption of high fat content. There is a story of the gentleman who went on a 30-day eating nothing but fast foods. And a lot of his markers in his body changed tremendously. So the idea is we need to decrease our incidence and our intake of fatty foods, eat a greater percentage of fresh fruits and vegetables, the exercise. Of course, nobody is exercising now because we all have our computers and our phones. And consequently, low incidence of exercise. Those are the ideas, but for African Americans in general develop colon cancer at a younger age. and consequently, that's the recommendation from the American College of Gastroenterology now. Get your screening started at age 45. And if there's a family history of colon cancer or any of the other cancers that I mentioned, ask the doctors if they have tested the markers in those cancers so that other family members can be tested. I can tell you about one patient of mine, African-American gentleman, who came to me and said, I want to get in your clinical trial. I've heard about it. I want to get in. I said, well, I do have to explain it to you. I heard enough about it, he said. I want to get in it. You don't understand, doctor, that I am the oldest living man in my family. My father had 7 brothers. All 8 died of colon cancer. And they were younger. My sisters had breast cancer and so forth. So he got in the clinical trial. We tested his tumor and him, and yes, he did have the gene. But then we tested his children. 3 of the kids had the gene, 1 did not. So his children were in their 30s. They have been continuously followed at the center, polyps removed, but neither one of his 4 children has developed colon cancer.
Great. Thank you so much, Dr. Mitchell. Thank you. So,
know your markers.
yes, know your markers, and then remember that colorectal cancer screening, particularly if it's colonoscopy, is actually preventive, right? So you heard Dr. Mitchell talk about polyps being removed. We know that polyps are the first step to the development of colorectal cancer. So in addition to it being screening, it also is prevention, so just remember that.